Good evening, everybody. First of all, I want to thank the members of the public for attending this important event tonight. My name is Brad Rasmussen. I'm the Chief of Police for the City of Lakeport. The Lakeport Police Department and the City of Lakeport are sponsoring this event tonight. It's being paid for by our opioid settlement funds. Also, I want to sincerely thank the Lakeport Unified School District Food Services Department for providing that wonderful meal that's available to you out there. I also want to thank you. I also want to thank Sam Houston Productions for live streaming and recording this event tonight so that members of the public who could not be here can see it on either YouTube or Facebook. What this event is tonight, Sam, can we get the PowerPoint? What this event is tonight is a community discussion on the opioid epidemic that's going on in our country, our state, and right here at home in Lakeport and Lake County. This is a very serious issue, and that's why we're here tonight. So the event is to start a discussion with you to engage the community and try to have an impact on our situation here, try to end the opioid epidemic right here at home. So first of all, I want to introduce, we're going to have several speakers tonight. First of all, Justin Phillips from Overdose Lifeline, and then her partner Jennings, also with Overdose Lifeline. Sarah Weber with SafeRx here in Lake County. Our sheriff, Rob Howe. Our behavioral health director, Elise Jones. And Diana Lunas, who is a peer parent coach with Partnership to End Addiction. So it's our goal in bringing you this collaborative event to end opioids in our community, and we're working towards this as a partnership with all of our local agencies. Because to have an impact, we need several components. We need the enforcement with law enforcement. We need the education pieces to educate our youth and our community. And then we need the services that are available, the substance use disorder services, the counseling, those kind of things that our behavioral health department runs and manages in our county. But most importantly, we need you, the community, to support us and be behind us, be behind all of these collaborative agencies to have an impact, help spread the word, educate our community. And with that, again, thank you for coming. I'm going to turn it over to Justin, and she's going to do the first presentation. Thank you.
Thank you so much, Chief, for bringing us here. Thank all of you for coming out on a Wednesday evening. I am Justin Phillips, and I'm the founder and CEO of Overdose Lifeline, and we are a nonprofit. We're actually in Indiana, but we do a lot of work across the country. And so a couple things I'm going to do tonight was, one, I'm going to talk about stigma, as you see up on the screen, because it's a really important component to the barriers that interfere with our ability to really address substance use disorder as a chronic disease that affects our country in a lot of ways more than any other country. And then I'm going to talk about opioids and the public health crisis a bit and some other elements to the conversation for tonight. So the first thing I'm going to do is talk about stigma, as I said. And I don't know where stigma started in my life. I think it was always this dark cloud that hung over my head, but I've learned a lot about it in the course of my journey. If you could go to the next slide, please. So these are my children. This is my family. I have 3 children. Brian is the oldest. Audrey is the youngest, and Aaron is my middle child that you see alone over to your right. And as a person who is fairly well educated, I myself have been in recovery from alcohol use disorder since 1989. So I thought I understood addiction. I talked to my children about addiction. I've fought with Aaron about his marijuana use, but I didn't understand opioids. And I don't think any of us really understood opioids. When Aaron came to me and told me that he was using heroin and could not stop on his own, I didn't really understand the ramifications. And I had shame and stigma. It is part of our culture. It is part of the fabric of the way we exist. And because of that, I didn't address Aaron's use of heroin as a chronic disease. I didn't go to work and tell my coworkers. I didn't talk to anyone about it because I didn't want to be judged. As someone in recovery, as a parent, all the things we do. We're told, have family dinners. We're told to do these things that I did, but yet Aaron found his way to opioids through a variety of ways, and I'll never know which came first for Aaron, the chicken or the egg, and it doesn't really matter. His legitimate prescription or his developmentally appropriate experimentation. But opioids are highly addictive and dangerous, and he unfortunately lost his life to an overdose in 2013. Can you go to the next slide, please? So we have differences that we see in each other. In our culture forever, we have judged each other by our differences. We've been doing this since the beginning of time. Way back when Jesus was walking the earth, we judged people by their leprosy. We assumed it was a moral failing. We have set each other aside by our differences as long as we've been walking the earth. Next slide, please. We're judgmental. As a human race, we compare ourselves to others. We compare ourselves by how we look on the outside. We do keeping up with the Joneses. We ask each other what we do for a living, what kind of car we drive, what milestones have our children reached, and we put these parameters on our abilities, and it builds shame and stigma within ourselves. Next slide, please. The social ranking theory of Gilbert and McGuire proposes that shame arises as a result of one's perception at one's social status. In social situations, people compete with each other for acceptance, approval, and attractiveness. We are hardwired for connection, and we are constantly looking to be accepted and approved of. And if we find ourselves in a situation where our social status and ranking isn't enough, we internalize and we have shame and stigma. Next slide, please. We learn at a very young age how to measure our good enough. And unfortunately, our young people have a bigger burden than we ever had, at least those of us in the room that are old enough to remember what it was like without social media. And I never would have thought I would be the type of person to say, that video games and all of that technology has caused us harm, but we now have, filters for these young girls so that they expect to look a certain way. And we have social media that tells us how much we're liked. And all of those things contribute to our shame and our not good enough feelings that we've been indoctrinated in our culture. Next slide. So as you can see here, shame and stigma are marks of disgrace and a set of negative beliefs that tell us that we are not good enough and we can internalize. Next slide. Toxic shame is considered a deep-seated feeling of being unlovable and unworthy. Toxic shame is what can cause a lot of trauma and internalized reasons for someone to use substances. Next slide. It's really the fear of not being good enough, not mattering, and being a failure. When we experience this different from others, we experience fear, and fear drives us into defense, which often creates judgment. Substance use disorder. My child suffering from addiction. There is no simple solution. There is no Excedrin I can take to remove my addiction. And because I don't have an automatic solution, I have fear. Fear causes me to act out in ways with my child out of anger, and subsequently, then my child has his own shame and stigma about his substance use disorder, and we are not helping one another. Next slide. Lots of people, sorry. Sometimes I get ahead of myself. But these are all the reasons that I have already mentioned, that I had my own shame around Aaron's use, around my own recovery. You know, we are anonymous if you work a 12-step program for a reason. But that doesn't mean I can't share with you that I have found recovery, because recovery, just like any other chronic disease, is important for people to have hope. But I had toxic shame around that. I didn't believe that I could do that. Next slide. So substance use disorder has been a chronic disease, according to the American Medical Association, for a very long time. It is a chronic disease in our country more than any other chronic disease. Yet we don't dedicate the resources to the research. We don't pay the professionals what they deserve to be paid to treat this chronic disease. And we have people who don't believe the science. Plenty of people who still believe substance use disorder, addiction is a moral failing and a lack of willpower. Next slide. When someone uses substances, their brain changes. So we have what is called neural pathways in our brain. So if you think about when you drive regularly to the same place every day, sometimes you don't even remember driving because you've done it so frequently. Sometimes cows will wear a path in the field, and they always walk that same path. Similar, we have paths in our brain that are our habits that we do without thinking subconsciously. And when we use substances, we do neural connections. And it's very hard to undo those. And that is why substance use disorder is considered a chronic disease, because the brain as an organ is affected. Next slide. But 76% of Americans believe that substance use disorder is a moral problem. We're never going to be able to address addiction until we stop believing that. Next slide. I said this. Go ahead to the next slide. So we're flawed, you know, and I said this before. I believed there would be so much judgment every time I stand up and talk about Aaron and the fact that he died from a heroin overdose. I know someone will judge me, but I had to do that in order to make a difference for someone else. Because I believe, and I don't say this to make myself guilty, but the shame and the denial that I felt contributed to Aaron's loss of life. And I say that for me because had he had another disease, I would have taken him to treatment. I wouldn't have let someone else do it so I could go to work. Next slide. I often provide the comparison that if somebody has cancer or another chronic disease, or they lose a loved one, we rally around that person. We bring them casseroles. We make a food train or a meal train, but we don't do this for people who suffer from substance use disorder. We don't have our own color on the NFL football field. And as I said before, we don't invest enough resources into treating this addiction, this disease. Next slide. It's hard because the behaviors that come from substance use disorder cause harm to people that love them. Individuals with substance use disorder lie and they steal from the people that love them. And it's very challenging because it makes us angry. And we need to start having a more harm reduction approach. And I understand how hard that is to get your head around. As someone who comes from traditional abstinence-based recovery, I couldn't understand it either. But a harm reduction conversation with my loved one goes something like this. I don't want you to use, but I know that you're going to use. So could you let me check on you in the event that you overdose so that you don't die? And when I say that to my loved one, their shame and stigma around their drug use changes and the dynamic changes. And it happens all the time. Next slide. We know in our culture that people with substance use disorder have been denied life-saving medication. I think California does a good job. I know SafeRx does a good job of access to the overdose reversal drug, but I've worked with a lot of first responders in other communities who say that they will not save someone after a repeated occurrence of overdose. And no one finds recovery without life. And I don't believe we would do the same thing if someone suffered from another chronic disease. We don't judge people for their chronic disease of type 2 diabetes when sometimes they forget to check their blood sugar. But we judge people with this disease. This is the only disease where we don't adjust the treatment plan, but instead we kick someone out of treatment. Next slide. I think this quote speaks for itself. The majority of healthcare professionals hold negative, stereotype views of people who use illicit drugs. I know it's hard when that same person comes back to the emergency room time after time, but we have to change our behaviors in order to help people. If I'm using substances, I promise my shame about my drug use is worse than any judgment you can place on me. And I can't find recovery if I feel judged and shamed. Next slide. It's an invisible barrier, stigma. It interferes with my ability to ask for help. It causes the family of the loved one an inability to ask for help. And if the family doesn't get better, the individual can't really get better. Next slide. Compassion and connection is so important. As I said earlier, we're hardwired for connection. And if we could start with compassion, if we could try to see people where they are, then we would be able to understand perhaps every one of us come to the table with a story, and that story leads us to behave in certain ways in our interactions. Next slide. Being kind and understanding toward oneself during pain and failure and perceiving one's experiences as part of the larger human experience is something we could all take into consideration when we see someone behaving in ways that we don't understand. Next slide. Compassion will help people overcome their fear and their stigma and be able to ask for help. Next slide. So as I mentioned before, we have to talk about it, and we're so grateful that this conversation is happening tonight and that you'll all get an opportunity to engage in questions with all of us on the panel about all the different ways we can talk about substance use disorder. Next slide. Adult adverse childhood experiences are really important for us to consider when we think about compassion and our stigma around substance use disorder. Adverse childhood experiences is a simple 10-question survey. It's not the right word. There's a lot of research behind it. Your attorney general at one point in time used a lot in California. But it basically tells you how many adverse childhood experiences have you had. And they can range anywhere from your parents were divorced, to you witnessed violent acts, to someone using substances in your home. But I think that if we understood adverse childhood experiences, we could understand each other better. What if we could walk around with a cartoon bubble behind our head that said what our ACE score is? How would we treat each other if we knew that you had a 10 and I had a 3? How could we interact better if we understood the role trauma plays in someone's story and their use of a substance? Next slide. We have policies and laws that need to do better. You know, we have health parity in this country that we don't follow. We can do better with access to treatment. We can do better with insurance coverage for treatment. It's very hard for someone to get treatment for opioid use disorder because a medical detox is not required. But the detox and withdrawal from opioids are why people continue to use. Next slide. We can talk about what we learned, and we can tell people about the changes in the brain that come with substance use disorder. We can let people understand that when youth use substances before the age of 15, they're 5 times more likely to use substances later in life. Next slide. We can get in front of the schools. You know, we saw 1,600 students today talking to them about the risks and the dangers of fentanyl, which I'll talk a little bit about in a little bit. And we can continue to get in front of the kids and help them understand a substance is not a solution. I think our kids are in trouble, and I think we got to help them understand alternatives to whatever's going on for them, and it's not about substance. And I've said this already enough times that we have to do better with embracing this chronic disease and putting resources toward it. Next slide. So youth and young adults, I mentioned this already. You can go ahead. Language, really important. There's a lot of stigmatizing language that we use that we don't even realize. Abuse is a stigmatizing word. We really need to stop saying abuse. And the National Institutes of Drug Abuse still say it, so I don't know how we change the federal government. But we can change it for ourselves. We used to say misuse, and now we don't even like to say misuse. We just like to say use, substance use. I can call myself an addict, but I don't want you to call me an addict. We can say people who use drugs. We can say setback instead of relapse, because it is a setback. I need my treatment plan adjusted, just like with any other chronic disease. Language is a really simple first step. Next slide. This is a quote from one of our great leaders in the Office of National Drug Control Policy about the language that we use. Michael Botticelli was a person in recovery who was a great leader. And this is important for us to have leaders who understand and have personal lived experience. Next slide. So here I got ahead of myself. Go ahead and click because there's a few. We don't like to say addicted babies. Those little babies aren't addicted. They were born with drugs in their system. Go ahead, thank you. So here's some things you can do, and I talked about some of these. We can vote for candidates who support treatment and recovery. We can support local issues. We can come out to events like this and then go share what we learned. We can join organizations. We can talk to the media about stigmatizing language and stigmatizing images. When the media uses those images of the needle and the spoon and the syringe, those are stigmatizing images. They make me, as someone who uses drugs, feel some kind of way. And when I feel some kind of way, I feel no hope, no efficacy, and I don't find recovery. Next slide. So this is our website. If anyone has any questions or comments or concerns about some of the stigma stuff that I talked about, I know it's kind of this invisible barrier and hard to understand, but I think denial and shame and stigma are the things that keep us sort of stuck out of recovery. And the more that we can be willing to share with one another, me too, I have that experience too, the better off we're going to be. So if anyone has anything about stigma, I'm happy to address that. Otherwise, I'll go to the next. So thank you, Jeremiah. So the next thing I'm going to talk about is a community action plan, which is a perfect lead-in to the panel because I'm a high-level solutions and some of the things I've already touched on, and then the panel behind me is really about what's happening locally and what else can be done. So go ahead. So as I already mentioned, we have 43 million Americans who suffer from this chronic disease. This is more than any other chronic disease in our country. We have had an increase of 46% of overdose deaths since the COVID-19 pandemic. It's a treatable disease and it's preventable. And there's a lot of things we can do. Next slide. Sorry, Jeremiah. Yeah, sorry. But we can't do it alone, right? The chief can't do it by himself. Behavioral health can't do it by themselves. It has to be a community-wide effort. Everyone has to get involved. Everyone has to be on the same page with the same level of information and the same agreement to a solution. Next, please. There's a lot of research behind using a cross-sector collaboration and getting all of these organizations involved. Everyone needs to be involved, including the faith organizations. You know, the faith community is a place where people go. And our faith leaders need to be willing to have these hard conversations. And a lot of times they're the last ones to the table, no disrespect if someone's in the room, but it's been hard for us to get the faith leaders involved. And that is a place where people are willing to go and bare their soul. Next slide. So let's talk a little bit about how we got here in the first place. Go ahead. So we have had a lot of loss to overdose and drugs since 1999. We have lost 1.2 million people. All of these deaths were preventable. If we add up the wars that this country has participated in and the people who have died from drugs outbeat the wars. But we don't talk about it. And I've said that so many times, you're probably tired of me saying it, but I feel like it's the solution. Like, we have to talk about it. We have to be willing to have the hard conversations. Someone dies every 5 minutes. 301 people in our country die every day. And it's really a U.S. problem. We consume 80% of the world's opioids, but we are 5% of the population. Next slide. So for those of you that didn't know, because I didn't know, heroin and prescription pain medicine are the same drug in different chemical makeup. Hydrocodone and heroin, semi-synthetic opioids. I had a dad once say to me, well, my child died from pills, so your child is worse than mine. But the truth is, it's an opioid. Heroin's got a bad rap, and heroin is the thing. You know, if any of you ever in the room ever did drugs, probably you said, I'll never do heroin, because that's the thing. Like, those people do heroin. And that is why I didn't want to tell anyone what Aaron came to me and said. Because the truth is, yeah, we judge that. But they're all opioids. If you could click. And now we have fentanyl. And fentanyl's been around a long time. We use it in surgical settings. It comes in a patch form. People use it for chronic cancer patients, late-stage chronic cancer patients. But then the drug cartel discovered it's cheaper to manufacture fentanyl than it is heroin. And fentanyl is stronger than heroin, and I can get you interested in my product with some fentanyl. And so I'm going to start manufacturing fentanyl and stop manufacturing heroin. And it's deadly and dangerous, and it's really what's killing everyone right now. Next slide. But opioids, despite what they told us way back when, are highly addictive physically. Any one of us in this room, if we have a legitimate prescription, become physically addicted within 5 days of using. Then I stop using and I feel these physical symptoms, which are withdrawal. And I think my pain has returned from my original occurrence, and I need more prescriptions. And we found ourselves stuck in the cycle of people misusing with not understanding it was really their physical withdrawal. And lots of people, including my almost 70-year-old neighbor, went from a legitimate prescription to purchasing prescriptions on the street, and ultimately to heroin because she couldn't get those prescriptions on the street. Next slide. So I mentioned this already, but I'll just say it again. 6 out of 10, go ahead, click. 6 out of 10 of the pills that are seized are illicit fentanyl. There are pill presses that make a pill look like a Xanax that is no Xanax in it. Adderall the same. We have a lot of young people. The numbers in the age group 15 to 24 are very high because of these these counterfeit pills laced with fentanyl. It is the #1 cause of death for Americans 18 to 46. And we have to be willing to talk to anyone about anything that you purchase that doesn't come from a pharmacy or a doctor has the potential for fentanyl. And there are solutions to that, harm reduction solutions that I know can be controversial. There are what's called fentanyl test strips that just tell you if there's fentanyl in your pill, and then you can make a different decision. We encourage those kind of things because we're trying to prevent overdose in the same way we encourage overdose reversal agents like naloxone, otherwise known as Narcan. Next slide. So here's some data, if anyone cares about data. If you could just click. We call these the 3 waves because we started with prescriptions, and I said this earlier. We overprescribed tremendously. We made pain a vital sign. We made doctors' reimbursement tied to patient satisfaction surveys. We made a mess with prescription pain medicine. And then we found out it was not a good idea, and we cut people off. And so they went to the second wave, if you could click, which was when heroin was really causing all the overdoses. And now we're in what we call the third wave, which is the fentanyl, which you can see is the yellow line. And the dramatic increase in deaths. In the last 2 years, we've gone up 44%. Next slide. So if you like data, I told the kids today, who likes math? Not me. But this is the map of the U.S. And this kind of shows the deaths in 2021, which is really the most recent accurate set of data in the states, according to the deaths per 100,000. So you can see, California's not the darkest blue there. West Virginia, Kentucky, Tennessee, Louisiana, and New Mexico are the worst. Go ahead, click. And as I mentioned, 42% over the last 2 years. So this is the crisis of fentanyl, and I don't know if it's a wall that's the solution. I don't know if China is our problem. I don't know, because that is too big of an animal for me to address. But what I do know is that the people who want to sell me drugs know that if they get me fentanyl and I don't die, I'm going to want what they have. And that's their goal. Okay, click. So here we are in California. We're 26.6 per 100,000. There were 10,901 deaths. This county is the second largest number of overdose deaths in the state of California. And I know the chief has some data that he'll share about what they've been doing locally to seize counterfeit pills. If you could click again. So I mentioned this before, this age group is up 55%. So it's very concerning. This is a whole generation, I believe, that we need to help. Next slide. So these are just more numbers about the youth and the drastic increase that took place. Go ahead, next slide. Sorry, Jeremiah, next slide. Thank you. I'm sorry, the clicks. And all of these teens are fentanyl. Go ahead. So here's your California trend line, similar to what I showed you earlier, almost 12% increase from 21 to 22. Go ahead. And again, almost 90% of these deaths are related to fentanyl. Go ahead. Here we are in Lake County, just to give you an idea of some of the numbers related to the surrounding area. 27 per 100,000, with Lake reporting 84 per 100,000. Go ahead. So what can we do? Click. So these are some of the 8 proven solutions that we know we can all do together, and I've talked on some of them. Harm reduction is really a set of public health policies that we use every day. Do you wear seatbelts? Harm reduction. Do you wear sunscreen? Harm reduction. How about vaccinations? Yeah, COVID-19 vaccine, a little controversial, but we immunize our kids most of the time. Harm reduction. Harm reduction for opioid use disorder is naloxone. It's medication. It's other things that are slightly more controversial that we won't talk about tonight, but it's a public health approach that actually works. Reducing the stigma we talked about. Oh, sorry. Can you go back? Thank you. Screening and early intervention is really important. There's a tool called the SBIRT that we could do in primary care offices We could have conversations with families. If substance use disorder runs in your family, you can have that conversation. You're 4 times more likely to have substance use disorder as an adult if it's in your family. Doesn't mean you're going to, but we could have those conversations. Education in the schools, another big one. Go ahead. Go ahead. Safe prescribing guidelines. You know, we have some laws around what we should prescribe and how much prescription pain medicine we should prescribe, and we can follow these. We can be our own consumer advocates when we go to the doctor. We can ask for non-opioid solutions. They exist, but we don't get told about them because the insurance doesn't want to pay for them. They want to pay for opioids because it's cheap. So that bundled outpatient surgery package for my knee replacement comes with opioids. And they're not going to tell me, well, Justin, you could do a blocker instead because it's hundreds of dollars over pennies. But I can be my own consumer advocate and I can say, I don't want 30 Vicodin, I only want 7 days. I can ask my doctor, are you following safe prescribing guidelines? Go ahead. Go ahead. Yep. Click, please, Jeremiah. We can manage our prescriptions. You know, if we have them because we need them, we need to safely store them and we need to safely dispose of them. We need for there not to be a bunch of extra hydrocodone in your medicine cabinet just in case. Because people with opioid use disorder are going to look for them and they're going to find them if they can. So we have to manage them, especially when we're talking about young people. We don't want them to have the temptation. Next slide. We have data and prescription drug monitoring, which means that physicians are required to do better about overprescribing. Go ahead and click. Go ahead. And we can talk about overdose and the reality that people are more likely to be overdosing in public spaces than they are to be requiring CPR. And even if we don't think we're ever going to be in front of someone overdosing, we can still be prepared because it's highly likely. And people are overdosing in public spaces, and we can recognize it and we can be ready. And I know that SafeRx is going to talk about that tonight and has, you know, overdose reversal kits available, which is really great. It doesn't hurt to have it. Go ahead. Who is at risk for overdose anyway? Do all of you know that people who are at risk for overdose aren't just those people, but they're also people who have respiratory distress for other reasons, because the number one cause of, the number one side effect of an opioid is respiratory distress, despite what the commercials tell us. So if I have sleep apnea or I'm taking other medications that depress my respiratory system and I take a pain medicine, I'm at risk for overdose. Children in the home that come across medication. People who drink alcohol and take a prescription. People who use. People coming out of incarceration or treatment are 169% more likely to die of an overdose in the first 2 weeks following their release if they use drugs. So understanding who's at risk. Go ahead. And in case you didn't know, these are some of the simple signs of someone who's using opioids. You know, I didn't know. Pinpoint pupils. I didn't have the experience of some of these, but I've heard it from lots of other parents. You know, all of a sudden I didn't have any spoons left in my drawer. I found, half cut straws or broken pens, valuables missing, wearing long sleeves in the summertime. Not being able to stay awake at inappropriate times is also a sign of opioid use. Next slide. So if someone is overdosing, they won't be responsive. You can rub them on the sternum, they won't be responsive. They may or may not be blue, they may or may not be breathing. If you don't know, it's okay. If there are no opioids in their system, naloxone won't hurt them. If you have it, give it to them. Call 911. Go ahead. Go ahead. Get a community action plan. I think California is doing a great job. I think SafeRx is doing a great job. Access to naloxone is really important. Next slide, please. We have lots of access in Indiana, different than other places. We have found that people still don't want to talk to another human being, so we have put things called nalox boxes in public places where people can go and get naloxone without having to talk to another human. The less the barrier, the more likelihood that we'll get the naloxone into the hands of the people that need it, love someone, care about someone, and can be prepared. Because right now I think we have to be prepared to respond to the overdose with the fentanyl in ways that we have never been before. People who think they're getting a Xanax don't think they need naloxone. Naloxone works on fentanyl. It just takes more doses sometimes, but it works. Go ahead. But what naloxone doesn't do is make people use drugs more. That's not true. Access to naloxone doesn't say, here, you have my permission to use drugs. What it says is, here, I want you to stay alive until you can find your way to recovery. It's just a bridge between 911 and treatment and help. It's not going to work if there's no opioids, and it's not going to do anything if there's no opioids. You might need lots of doses, depending on the level of what the individual has used, and it might not work if there's other drugs in their system. And the most important thing is that you got to get medical intervention after administering naloxone, because naloxone has a shorter half-life than the opioid. So I might be okay from my overdose reversal, but if I don't go to the doctor or the hospital, I can re-overdose. Next slide. Go ahead, please. So I talked about this earlier, our need for meaning and connection, and that addiction arises out of dislocation, and the absence of meaning is yet another dislocation that we as humans, I think we have a lot of disconnection. I don't know why we have so much despair. I think it has to do with the stigma stuff and the differences that I talked about earlier. Next slide. Recovery capital is a really important concept. We talk about social capital, but recovery capital is something we can do as a community. What are we doing to increase someone's efficacy around their recovery? Do we have a recovery community organization? Is our only recovery support 12-step? That's not for everyone. What else can we do? Are we using peer coaches? Do we have access to peer coaches in the emergency department? What are we doing to help someone understand? How are we helping them meet their basic needs? Because if I'm too worried about where I'm going to sleep tonight, having recovery is not going to be my first priority. Next slide. So it's important to have strategy, and I think that's why we're here tonight, and building the strategy and what else can be done. Next slide. Involving all the people, all the cultures, all the differences that we have. What do people need? What's different for the tribal nations than for me, the white mom? How can we work better together? Next slide. So Overdose Lifeline has some programs that we have been using with some partners across the country, and I just share them briefly. If you could go ahead, Jeremiah. We have some continuing education courses online to help the community sort of come from the same level of knowledge. And some of these courses meet the wonderful federal act that just passed requiring physicians to be educated in substance use disorder, which is a big step because a lot of physicians don't understand. So these are all available online, and we have lots of partners across the country that use them. Next slide. It's a 20-hour certificate, or you can do them individually. Go ahead, Jeremiah. We train community partners. We've trained some community partners actually in the area, including Redwood Community Services, and we have some partners at Humboldt. Go ahead. And we have some youth prevention and education programs. Go ahead, Jeremiah. So we have this program called This Is Not About Drugs. This is what we did with the youth in the last 2 days. 2 days. Right, Megan? Feels like longer. But anyway, lots of kids. And they were great kids. It is what we call a universal program. So it's really a message for anyone in the room. And we have partners who use our program in addition to us doing it the way we have in the last 2 days. Next slide. And then we have this program that I believe in 100%, and it's not our program, but we are licensed to train others, called Preventure. And it is based out of Canada, and it talks about personality risk factors for substance use disorder. And we teach the kids through motivational interviewing and cognitive behavioral therapy that if you have anxiety, the substance is not the solution, but here's some other things you can do. And we teach the kids negative thinking. Or Aaron was, this risk taker. Happens to be a personality risk factor. What it feels like in your body and how you can make a different decision. Look, 5 minutes. I'm sorry if I talk too fast, but I wanted to make sure that I got everything in the time that I had. So we are now going to transition to the panel, and thank you so much for listening.
Thank you, Justin. And now I'm going to bring up Jennings, who's also with Overdose Lifeline.
Hi, guys. Good evening. So my perspective is a little bit different. I come at it from a person who struggles with addiction, who's in recovery right now. But just to kind of give you a little bit of a different perspective possibly on your end. I got married. I had 4 children, a great career in my 20s, a bank manager. But I never had addiction problems. I did suffer from migraines pretty extensively, and in my 4th pregnancy, I had gone to my gynecologist, and she felt that it was the safest option for me to be prescribed hydrocodone during my pregnancy. She didn't want me to take my preventative medicine anymore while I was pregnant, and so that's what I did. But the thing about this pregnancy is that for whatever reason, I was getting migraines every day. And so I took Vicodin every single day until one day I ran out of my prescription, and I woke up and I felt really, really sick. And I didn't know that I was withdrawing at that moment until I went to the pharmacy and filled my prescription and realized that I was physically addicted. So with me, like in a lot of other people's stories, my story started with pill addiction. And when those pills stopped being prescribed to me because I had my child, my addiction didn't just stop. I was then forced to go to the streets and buy pills that way. But even then, pills ran out on the street. They became too expensive, or doctors were starting to stop prescribing. And that's when I went to heroin. So, there's a lot of, working citizens or people that might be educated, or, mothers and fathers and pastors and doctors. Everybody can become addicted, and that's what's scary. It's not a specific type of person. It doesn't discriminate. And I think as society, we look at a person, or we have this box, and we think that, addicts are the guy under the bridge, or, the troubled teen. I can tell you that wasn't my situation. And the shame that I had from that, because of my community looking at me a certain way, was really heartbreaking. I felt like I had no hope. I had no help. People didn't understand. And I really felt like I was at it on my own, that I had to figure this out on my own. Something that I think is important for every community, something that helped me so much to get sober, is finding my community. So that was somebody who's gone through it, who's been an addict in recovery themselves, and they showed me a way in which I could get sober. Yes, doctors and nurses and all of that were really helpful, but I just really wanted to hear it and see it from somebody who's been there. So recovery coaches are huge, or anybody that can just share their experience and give a little bit of hope. I struggle with opioids, and I'm going to struggle for the rest of my life. It's going to be a chronic disease. I'll never be able to take a pain medicine again. And I hope that I never go back out. But I know that having a community that's strong and doesn't have stigma is going to help so many people. So I wish that for all of you. So thank you for letting me share.
So now we're going to start with a panel of local experts with the goal of letting you know what we're doing here locally, what services we have available for the community. We're going to start with the law enforcement, and Sheriff might not like me saying this, but I just realized sitting up here how old he and I are getting. We worked together 30 years ago in the narcotic task force, and so we've been around a while. We've got a little bit of experience on what the drug scene has been here in Lake County, and what it is today is completely different than it was 30 years ago when we worked together. We certainly did deal with opioids, but we didn't have fentanyl back then, and now that's exploded. It's 50 to 100 times more powerful than the opioids we were dealing with. So it's here, it's scary stuff. Your law enforcement agencies here locally are seizing it on a regular basis. We're seizing it in pill form, powder form, and various different looks on a lot of these pills. Commonly they look like a pharmaceutical pill that would be a legitimate, say an oxycodone or something like that, but they're actually counterfeit and they're fentanyl. So it's serious, and I'm going to now invite Sheriff Rob Howe up to give us some information on some of the seizures and other things that have happened here locally. Thank you.
Okay, I don't know what the chief's talking about, because no way we look like we've been doing law enforcement for 30 years. I'm kidding about that, of course. So, Rob Howell, Lake County Sheriff. I'd like to start out with a thank you to Chief Rasmussen, Lakeport PD, the city of Lakeport for sponsoring this, and of course all of our partners for participating, and the community. It's a huge issue that we're dealing with, huge problem. It's going to take community involvement. It's going to take this kind of cooperation and communication. So thank you all for being here. Chief Rasmussen asked me to just come up with a couple stats from the sheriff's office to basically show that fentanyl specifically out of the opioids is here. It is something we're dealing with. He said no long speech or presentation, so I'll abide by that. Keep it a little bit short. I started out just running up a few stats within my department. We have a unit called our Roadmap Task Force. It's just 2 deputies and 1 sergeant, very small unit. We assign them to an area. It's currently Clear Lake Oaks, and we ask them to just be proactive. They don't have to respond to details. They handle problems in problem areas. I started looking at them, and in 2023, that unit, again, 2 deputies and 1 sergeant, seized 9 pounds, 4 ounces of fentanyl. Now let's put that in a little perspective. I read a DEA brief that said 1 kilo, 2.2 pounds of fentanyl has the potential, a lot of factors there, but the potential to kill 500,000 people. So in the matter of a year, 2023, 2 deputies and a sergeant seized enough fentanyl in Lake County to potentially kill 2 million people. That's a problem we're dealing with. And again, well, thank you. And I'm an optimist, and I like to think we're making progress. I'll mention this. Some of the stats I'm going to go over are 2023, and you'll see a little bit of improvement. Another area I looked at, other than what our seizures were, was our coroner's cases. Last year, we did, in 2023, 374 coroner's cases. Now, the Sheriff's Department is responsible for investigating all deaths in the county, not just homicides, not just suspicious deaths, but all deaths. Out of those 374, 36 were fentanyl overdose, at least suspected fentanyl overdoses. I mentioned that's a little bit down from the 2022 stat, but still way, way too high. If you think about it, that's 10% of our overall deaths were overdose related. And that's including everything from natural medical deaths, homicides, suicides, accidents, vehicle accidents. Again, 10% of our overall deaths, one cause, overdose. Last thing I really wanted to mention today that kind of drives the point home is we operate a jail, obviously, and I think the jail is probably the most secure, controlled environment we can imagine, right? We have a body scanner going in, we search, we do random searches of personal property, people, cells, and yet it still gets in. We still have fentanyl in our jails. Last year in 2023, we had 7 overdoses in custody. Out of those 7 overdoses, I should say this too, 36 doses of Narcan administered. There's people talking about Narcan, they're going to talk more about it. That's 7 deaths, basically, without Narcan, no doubt in my mind. It works. We'll get more education about that, but I just mentioned it to tell you that it's here, it's a problem. We're doing our best, making improvements. We're working with our partners. I think we're in the right direction, are going to go in the right direction, but this is what it takes. So thank you all again for being here. I'll be hanging out for questions. If you don't ask me up here, I'll be here for a while. Thank you.
Thank you, Sheriff. And now I'm going to bring up Elise Jones from our Lake County Behavioral Health Department. She manages and administers that agency. In addition to behavioral health work, they also run our substance use disorder programs here in the county. So I'd like to invite Elise up.
It's nice to see community out. I'm still kind of getting used to that, and it's a good thing. And I want to thank each and every one of you for coming out. These are important and difficult conversations to have. So getting to it, I want to spread the message that recovery is possible, and it happens every day. And it is never too late to step onto the path of recovery. I also want to say that our kids, as we're all aware, are really at risk right now. And it is absolutely true that we are not raising children in similar times that I was being raised in, where teens do experiment, especially younger people, and that's really developmentally normal, but never did I ever worry about overdosing when I was their age. So I want to shout out to Michael Moss and others of our prevention team. We have a lot of staff that go into our schools all year long and do a lot of outreach and prevention, just education and educating our youth, and that work continues. And feel free to ask any questions that you may have about that at any time. We also do substance use disorder treatment services, the whole continuum from outpatient services where people are able to meet with a clinician on an outpatient basis all the way to inpatient. I'm also happy to announce that Lake County Behavioral Health Services is the administrative entity overseeing our county's opioid settlement funds. Because of the prolific prescribing of opiates by physicians and a lot of stuff. The manufacturers of those opioids were sued successfully. And so our county's allocation, there's many allocations, both cities have it, as do tribes. Our county's allocation alone is a couple million a year, and this goes on perpetuity, I want to say, for about 17, 18 years. And so that's exciting. This is really a once-in-a-generation opportunity to invest in our community. Please talk with Megan Morgan over here, slyly recording, because we are going to hold 3 different stakeholder meetings to talk about these settlement funds, because we want our community to tell us what they need, right? And so the first one is coming up at the end of January. Thank you, January 26th. It will be from 9 to afternoonish. You will have to register, and 10 to 2. She's a details girl. 10 to 2, and that will actually be in the Lake County Board of Supervisors chambers in Lakeport. The other 2 meetings following up are to be determined, but again, that feedback is critical for us to develop a comprehensive opioid expenditure plan so that we can try to use those funds to combat the crisis facing our community. We are also entering into something called the Organized Delivery System on July 1st, which dramatically expands the scope of services available to Medi-Cal eligibles. So that right now, unfortunately, if you were to have a substance use disorder diagnosis and you happen to be a man over the age of 25, so you're not a kid anymore and you're not a mom and you don't have kids, if you need residential, it is not a covered Medi-Cal service. That's unfortunate. However, with the feds and the state of California, we're able to opt into that as a plan, demonstrating that we have the capacity to provide those services. So we anticipate moving into that expanded service delivery July 1, and more information to come about that. And I just want to, again, thank all of you for coming out tonight. Happy to answer any questions that you may have about behavioral health services.
Thank you, Elise. And now we're going to have Sarah Weber with SafeRx Lake County.
Thank you. As the chief mentioned, my name's Sarah, and I am from SafeRx Lake County, which is our local overdose prevention coalition. So you may have noticed as you were walking in a table with a bunch of boxes on it. Those boxes are all filled with Narcan kits, or naloxone, which is the generic name. And I encourage all of you to take 1 or 2 kits, or as many as you need. We've got plenty. There's more boxes under that little table if you need to take a look. And if you are part of an organization, a school, or a company that would like a Narcan training, please feel free to let me know. I am more than willing to provide training and kits. I also wanted to mention today that naloxone, while a critical intervention, is just one small tip of the harm reduction iceberg. And I specifically wanted to commend the work of our harm reductionists here in Lake County, including Any Positive Change. These people have saved thousands of lives, or at least hundreds of lives over the course of their operation. And that's the work that we need to continue to do if we are going to end the overdose crisis here in Lake County. Thank you.
Just listening to that, I think I may have left something out when I spoke of the overdoses in the jail. I talked about Narcan. None of those people died. Those were not deaths in the jail. Those were overdoses that were treated and saved.
And now I'm going to bring up Diana Lunas.
Thank you. I am not an expert. I'm a mother. I am a mother of 4 children, 10 years from oldest to youngest, 10 years of separation in age. 2008, we lost our oldest child to an overdose, and he had been in treatment and was working his recovery, and he died in Humboldt County. He was a student of Humboldt. I was not prepared for that, although I knew that he used. He was a delightful child of the 60s. He was an artist, a musician. He was really brilliant young man. and a student of world religions. But clearly there was something that he didn't want to share with us. There was a secret. He always was happy and wanting to do for others. But one time he said to me, "Mom, I've been peeing in a bottle for weeks. I'm getting Suboxone," and through tears, just sobbing, said, "Mom, I'm addicted to Oxycontin. And it's heroin in a pill, Mom. It's heroin in a pill." And, you know, I really didn't know what I didn't know. I had 4 cesareans, I got Vicodin, I took 1, maybe 2, and that was it, went to prescription medications. I didn't know what was troubling him. 3 surviving children. The youngest, well, Josh, okay, he was 27. The youngest was passed when he was 22 in our home from a fentanyl patch. He had gone back to school. He had his books around him. We didn't know that he had such anxiety following 5 months of residential treatment. Again, a child who woke me up days before because he had a fever and wanted me just to put a cold rag on his head and hold him. Why couldn't he have gotten up that night and said, "Mom, can we just watch movies? Dad, can we go fishing?" Why couldn't he have shared that? So it's been 10 years next week since we lost our youngest, and 16 years in June since we lost our oldest of 4. And for me, I led with love in the beginning because I had other children. I had no choice. It wasn't about me, it was about them. But I really began seeking a way that I could continue to love my children, though they were beyond the veil. I tried a lot of different things. I tried to find my way, and I was involved with many organizations. That's where I met Justin, in Atlanta and Washington, D.C., in advocacy. And I began to learn. And in my quest for learning, I tried many things, like I said. I started the chapter here for the Compassionate Friends. We've been meeting here for many years, once a month, people who've lost a child, a grandchild, or a sibling, for any reason. But about 5 years ago, I became connected with a group, Mobilize Recovery. It's an amazing group started by young people who had been Narcaned, several of them many times, and they were tired of their friends dying in sober living and on the streets. And they said, "We need to change something. We can't do this anymore. We're going to recover out loud." And they started this amazing organization called Mobilize Recovery. And it was during COVID, and I had a tip from a friend about training to become a peer parent coach with a partnership to end addiction. And that's what I did because I felt like I had found my people. It wasn't about me, it was about other people, other parents like me. Because there were things that we didn't know. It was a different time. And over the years in advocacy, we learned so much that we didn't know, but we also learned what was known that wasn't being utilized, the education behind the opioid prescribing, etc. Justin covered all of that fabulously. So I found my people, I went through the training. It was a really deep dive for me because as a parent, as a good parent, we all think we're good parents, but there are things that we don't know. And there are things, like Justin said, that keep them from being able to share their truth. And I found that I was a trigger just because I was sad, because I was helpless, because I was terrified. So a lot of the training rang true for me, but I stuck with it because I wanted to know this seems to be the path to be able to help families, something that we did not have and desperately needed. And I recognized that the training and the tools and strategies that I was learning about coincided with our parenting style. And it was painful to recognize that not only would it have helped us in continuing to work with our children in their need and to eliminate that shame and secrecy that they held so tightly to, but it would have helped them. So, for 4 years, I have been a peer parent coach with the Partnership to End Addiction. It's a volunteer role. I work with parents every week for a period of 6 to 8 weeks. And what we utilize are tools that have been developed by the Center for Motivation and Change in New York City. And the authors of this book, Beyond Addiction. This book, my oldest son would have handed to me and said, "Mom, read this, because you're going to learn all about me." And it's true. It's true. And so we have workbooks that we work with parents on, very careful to make them understand that none of us are so powerful that we can change an outcome. But what we can do is we can preserve the tribe. We can help them to communicate lovingly and openly and honestly with their children who are using or in treatment and recovery. Things like, concepts like behaviors make sense. Had someone ever said that to me, that would have opened my eyes and I would really have been listening. And beyond that, ambivalence is normal. I say this all the time. You try to lose the same 10 pounds over 10 years, there's something wrong there, but then, okay, they're selling Girl Scout cookies, so that's fine. I can do that and I can get back on it tomorrow. But if your child is using something that to them, they feel that that's their lifeline, there are ways to speak to them and to make them know that you honestly want to know how they're doing. And so that's what I've been doing for 4 years. I'm sorry, I'm getting off here, but I'm very passionate, as you can tell, about peer parent coaching. I have since become certified in the Invitation to Change approach, which is one of the workbooks that we work out of in our coaching. And my desire is to bring 8-week workshops to our communities here to try to help parents to know that there's another way and that they can change their perspective, perhaps look at things a little bit differently, and in the meantime, preserve the relationship that they hold dear. In the end, after losing half of my family, I can tell you harm reduction in any fashion means life to me, things that I wish I had known, wish that my children had not been shamed for medicine-assisted treatment help when they got out. Their addiction is this big, and trust me, they're this big. And sometimes that's all you need to know to help you to change your perspective when you're in that place of fear and frustration. Thanks.
So we're getting ready to wrap up this portion of it and open it up for questions here in a second. But again, I wanted to first thank the Soper Reese Theater for being our host tonight. I also want to thank the Lakeport Unified School District for donating and providing that wonderful dinner to us. I also want to thank Sam Houston Productions for live streaming tonight. Most importantly, I want to thank you in the audience for being here. But also, I am aware that there's people online watching on multiple channels. I want to thank them for being here and attending also. I want to sincerely thank this panel of people, Overdose Lifeline, our local agencies, SafeRx, the Sheriff, Behavioral Health, and our community partner, Diana Lunas. And I really want to give a sincere thanks to Justin, Jennings, and Diana for being willing to share these personal stories. I know they had a great impact on me listening to them. I've heard these ladies multiple times in the last 2 days. We have traveled around the county together, attending and presenting a similar program to this to our youth at the schools. In the last 2 days, we have spoken to over 1,600 students. And by the end of tomorrow, I think we're going to have at least another 1,500. So that's important to us to get the word out to our youth as well. So this message is going much further than just here tonight. We've been throughout the county all week. Again, a huge thank you to everyone. And now we're going to open it up for questions. All of the panel members are going to stay here. If people don't have questions or they don't want to publicly ask them, they're welcome to hang around and privately talk to any of these folks. So we're gonna open it up. We have an officer over here that'll have a mic. If you have questions, he will bring it to you, and it's important to do it that way because we want to capture it on our live stream, which will also be a recorded video. If there are any questions, raise your hand. We will bring a mic to you, and you can direct the question to the appropriate person. Do we have any? I'm not seeing any. We'll give it a second here. Yes, I have one up here. And then I'll get to you, sir.
Can you hear me?
Yes, can you please state who your question is for?
It's actually a law enforcement question.
Okay.
I was around back when you guys were talking about the drug task force, and I think it was relatively large back then. Can you tell me, is there currently a drug task force in this county?
So I believe you're asking about the task force. Yes, we had a multi-agency task force in this county for almost 3 decades. It started back in the 1980s, and it went up through about 2009. The sheriff and I actually were partners in there at times. We worked that together back in the early to mid 1990s. For various different reasons, mostly the state of California in the year 2010 was when they implemented realignment, and the governor decided as part of that to disband and eliminate the Bureau of Narcotic Enforcement, which was our sponsor agency. They provided the special agent supervisor. They paid for our office. They supported it. The local agency supplied officers. So that was the big reason. We do not have a multi-agency task force now. It's my opinion that this county needs one, and I'm going to let the sheriff respond too, because I'm not 100% sure on what his investigative situation is right now.
As I mentioned, we have the Roadmap Task Force. It's simply our department. We also have some investigators that do narcotics and marijuana enforcement, but we do not participate in a multi-jurisdictional task force. We want to. I know Chief Rasmus and I have talked about this as staffing permitted, and hopefully with funds maybe available. We would like to get back in that. It's just a very difficult time, as you can imagine, to have the extra officers to do that. But I think we did a lot of good stuff there. The numbers that I mentioned earlier are numbers that you can get when you have deputies that can be just proactive. So we'd certainly like to get back to that.
Todd, we have a question down here. Thank you, Sheriff. Right here, Todd. First, that gentleman.
I'm hard to see. Yeah, this is for anybody that can answer it. There's 3 parts to my question. One is, on a Narcan, is there a temperature limitation? In other words, if you have it in your hot car, is that going to negate it? Number 2, is there a lifetime on the materials? So if you keep it too long, will that be bad? And the third part has to do with the classroom and the beyond addiction approach. Is this been reduced? I know that you folks are making presentations, But has this been reduced to a classroom exercise where it's actually taught in the classroom for a period of time so the students get some exposure so they can answer questions under a classroom situation, become experts within their own school so they can help counsel their peers? Because that's a big part of the addiction, is peers influencing peers. So 3 parts, anybody can answer those 3.
I can take on those first 2. Narcan, I'll stand up. Narcan has a shelf life of 3 years according to the FDA, and it should not be kept over, I believe it's over, it should be kept at room temperature generally. Not over 100 degrees or under 32 degrees. That being said, studies have shown that expired naloxone is better than no naloxone, that naloxone that has been exposed to high heat or low temperatures is better than no naloxone. So if all you've got on you is naloxone that's been in a hot car, naloxone that's a couple years old, go ahead and use it. But we are here, SafeRx is here, we've got plenty of Narcan, and we are happy to replace that as needed. You can just give me an email and I will replace any expired or possibly neutralized naloxone.
Thank you, Sarah. That was actually what I would say too. So if I can understand your question correctly, are you saying, are we regularly in front of the students, just like we teach math regularly? No. Can you state it a different way? Okay, so I believe that you said, are we teaching the teachers to teach this information on a regular basis the way the teachers teach grammar or addition or division? No. And I can only speak from my experience but I can't speak specifically for local. But we teach to the test because we passed laws like No Child Left Behind, and we have standardized testing that students are required to pass. And we have little to no time in the classroom to do health education the way that we used to, and that's what this is really about, is health education. So if we go back to the policy and law stuff that I talked about and the things that we need to change, we have a crisis with our youth that I think was brought on a bit by pandemic that we aren't paying enough attention to. So we do our best through Overdose Lifeline and the partners that we have, but we need to do better to what you're saying. Anyone else?
Anyone else have anything on that one? Thank you for the question. Good question. Was there another one down here? Do I see another? Yes? No. Yes, there's one right there.
Thank you. Justin brought up the incidence of neural pathways. And so I guess that my question would go to Lake County Behavioral Health. Can you expand on that, the neural pathways? And are there specific guidelines that we have where we can try to get those neural pathways changed?
Well, that's a great question. I do teach a semester-long course on behavioral neurobiology, and we talk significantly about brain development, but the number one takeaway is that brains are malleable. They're plastic. And so the prevailing thoughts about brains for a long time was like, you can't teach an old dog new tricks, right? Brains become like cemented in at some point. What we've learned in neuroscience is that's not true. Brain plasticity is the rule and not the exception. And so that's just as easily, like right now, anything that you learn new tonight has literally resulted in a new physical connection between probably thousands, if not millions, of synapses in your brain. It's also true that the brain goes through really intensive developmental phases, right? Early childhood, the first 5 years, you've probably seen the first 5 campaigns. That's for a good reason. That's because that's when the brain does a lot of its cooking, for lack of a better way of putting it. And then again in adolescence. And so it's really important to capture our youth because that's when a lot of things are taking shape. However, people can change and recover at any point. And so it takes practice. And the analogy of a cow or a deer, in my case, I have a lot of deer around my house. You know, they form deer trails, and it's very easy to get stuck in the same rut. And so I guess the other takeaway from that is that compassion, right? Really reframing this as this isn't somebody who wants to do bad or they desire to hurt themselves or others. This is somebody who is ill, who has a sickness, a disease, and is not able to make better choices, even if they desire to do so. So I think those are the big takeaways from neuroscience. And again, the impact of adverse childhood experiences. And it was our Surgeon General, Dr. Nadine Burke-Harris, who, it's okay, she's one of my idols. And so she really brought like the ACEs Aware campaign where they do screening, because we also know that there is no bigger risk factor for a person than having trauma in their lives, to the extent that the state of California said any child under the age of 25 who has a history of trauma is eligible for specialty mental health services, even in the absence of symptoms, because that's how impactful we understand trauma to be. And so I think that's a really great step. So just a push here as well for mental health services, because often co-occurring people have depression, anxiety, or other mental health issues that often are friends with addiction, I like to say. They don't like to be a loner, and so it just is what it is. And so any child you know of that has had a rough time, anybody can think of kids in Lake County that have had a rough time. I know my family's has had its share as well, just from the fires alone, right? And so we're a community that's been ravaged by a lot of trauma. And it makes sense that we have the challenges that we do. I also want to say that this is an incredibly resilient place, just like people are, our community is, and our ability to come together and rally for solutions is going to help us get out of this situation. Thank you so much for that question.
We have a question right here, Todd.
Hi, this question is probably for Overdose Lifeline. When educating parents about harm reduction, I'm wondering how you address the stigma of fentanyl strips and what that ties to sex ed and condom use. Give us some understanding of that, please.
Yep. So I try to start it with sort of the example of having that harm reduction type conversation around, I don't want you to use, but I know you're going to use, and how the whole dynamic changes. In my community, and I know harm reduction is controversial, right, which is why I'm grateful Sarah said what she said, because I was trying to stay away from the controversy. I'm the outsider. But getting the parents to be willing to acknowledge that, as it's already been said, developmentally, I might try to experiment, and I'm being influenced by social media and all these other places to try these pills that aren't going to be safe. Being willing as a parent to not have denial around that my child might be doing this is huge. And I don't know what the solution is other than having these conversations and saying, you can't risk, you don't want to risk your child's life by not being willing to take these approaches. Fentanyl test strips are easy to use, and it's not the solution any more than naloxone access is the solution. But at minimum, it's going to cause a pause. And, we've had kids that we've talked to who've then gone to a trusted adult and said, would you help me test this Adderall I bought? And then there was fentanyl, and the whole dynamic changes again. But it's a great question, but difficult. The answer is hard.
Thank you. And Diana wanted to add an additional comment.
Thank you. In addition to what Justin was saying, you know, if we back up to our parenting, you know, it's a difficult situation to confront your child in a positive way and move to reinforcing good behavior versus reinforcing their continued use. But in educating parents on the things that we wish we had had, they have an opportunity to learn, but they have to be willing to go to that rough place, because that's what you're talking about when you're talking about harm reduction. And I view this as sort of harm reduction in the beginning, although I coach parents that are, the child is way into their use, but then some of them are just beginning. You know, they're using marijuana or they've been to parties and the parents are terrified. So that is something that we really need to open up the dialogue between parents to one another. And we can do that in the schools by having someone come in and talk about the tools that I mentioned in a PTO meeting, talking to the teachers because they have in-services, and having them maybe change their perspective on students that they suspect are using. I feel bad because I didn't really talk about my second son, but you know, he told me once that, Mom, there are people your age here making a living off of someone like me with depression and anxiety, because he was broken. He was 16, he was broken when his brother, 10 years older than him, passed away. That was shocking. It gives me the heebie-jeebies, Mom, to even go by the CVS. I mean, these are things that are really hard to hear. They're hard conversations to have with your child. But the tools are really, really important, and that's why I'm so passionate about it. And I hope that I'm able to bring it to our community via the schools or the hospitals or tribal health. I'm open to beginning these programs here for the benefit of parents, because that benefits your family and your children. I just wanted to say quickly, because I forgot to end with, Partnership to End Addiction. You may remember this is your brain on drugs. It's had many evolutions. But on the table back there with the naloxone, there are flyers. Take a handful of them to have them for people that you know, who parents who are worried about their child's use, because these are all free services, coaching and classes to teach you about craft. They have a helpline specialist that are ready. They have help and hope by text, so somebody is on the other line ready to get someone's text, and self-directed studies for parents that want to learn more. I apologize, I didn't finish with that.
Thank you. And we have a question down here, Todd.
Hey, everybody. First of all, I'd like to thank you all for doing what you did the last couple of days and what you're going to do in the future, seeing the kids and presenting what you presented to them, because that's where it all starts. That's where it all starts. Excuse me. But what I'm wondering is how did you motivate, or what did you use to motivate the kids to check each other? Like when they're out and about, how did you, hey, you know, if you see somebody getting a little bit carried away, you know, call them out and don't be afraid. Don't be afraid to call them out, because you could save their life, that sort of thing, if that's something that you used, and if you could share a little bit about that.
That's a hard question. It's a good question. So although I'm not a kid and I'm not a teenager, you know, I'm hitting 40, my addiction, you know, Like I said, it wasn't that long ago. I'll tell you guys, I only have 3 years sober. But, you know, motivation, even in my community that I was using with, so the people that I hung out with, we all knew about naloxone, right? We all knew about fentanyl test strips, and we carried those things. And I use an example. You know, there is a lot of stigma around naloxone still, or harm reduction tools. But, you know, the last time I was Narcaned, because I had overdosed many times, I was actually at my dealer's house. And my dealer had a huge box of Narcan. And even though she was my dealer and she was providing me with heroin, she also had something to save my life. And if I was not Narcan that day, I would not be here. And so, you know, somebody can't find recovery, young or old, unless they're alive. And so my 11-year-old son, you know, he's a spokesperson for Narcan now. He knows how to use it. He knows, you know, how to recommend it to people. He knows where it's at. And I even train him on those conversations. You're gonna be out with your friends someday, and somebody's gonna be using something. You know, show your friends how to use this Narcan. Carry it with you at all times. Show them that, hey, before you take that pill, test your drugs. And it's not because I'm saying it's okay to do drugs, but it's going to happen, and it's everywhere. So encouragement among kids. I like to just keep it honest with kids. You know, sometimes they don't want to hear all the medical terms and the statistics and all that. Sometimes you just have to talk to them like their age. And just say, hey, you know, encourage your buddies to slow it down a little bit. You know, tell them what you know about it, whether it be your own experience or what you've seen in your own family. So, yeah, we have to train our kids to have these open discussions. But by doing that, you have to have these open discussions with your kids. Make this normal talk at your home, normal talk at the dinner table. You know, nothing to be shy from. There's no shame. I think that's the biggest thing. And if they don't have any shame in the conversation with you, they're not going to have shame having conversation with their friends about it. So, I mean, I hope that's helpful, but thank you.
Thank you, Jennings. Are there any other questions? There's one here, Todd. Supervisor Sabatier.
Thank you very much for the presentation. Powerful stories. Definitely appreciate you sharing with everybody. I have two questions. There was a comment that was alluding to this, at least the opioid crisis, being a major problem in the U.S. versus other places. So my first question is, we've been talking a lot about how to help those that are already involved with the drug use. What can we do as a community to try to change something where maybe it might push people away from starting the drug use? What would be possible for us to change where maybe in other areas of the world they're not enduring the stress or the trauma where it pushes them to start looking for things to help themselves feel better? My second question is, and I just want to make sure we leave with people having the right information, if I was somebody that was struggling with substance use disorder, who would I call today, right now, to start finding help?
Those are great questions. And Elise, you want to take them both?
I appreciate them. So let me lead with the second question, actually. So also, we just launched behavioral health services effective January 1st of this year. We have a mobile crisis benefit. What does that mean? It means 24/7, 365 days a year, you can call our mobile crisis number or 988. That's also the easiest way, 988, which incidentally you can text as well, which might be a cool resource for younger folks who do prefer to text sometimes. I know I have three teenagers in my home, and they do like that. So 988, and why I'm mentioning that is that substance use crises qualify for the benefit. So if you're a person struggling with substance use and you feel like you're at risk of using a substance and not being safe, you can call 988 and they will come to wherever you are and help you as far as you want to go. That's a benefit that just went live January 1st. The first question to me is really like, again, you could take a semester-long class probably about that issue. And I guess I'm going to make the risk of being a little bit personal and philosophical here. And I'll talk about risk factors and protective factors. So across the board, what we know is that if you want to have good outcomes, you have to outweigh the risk factors with protective factors, whatever those are. So for me in my personal life, I have a 6, 8, 14, 15, and 16-year-old in my house. I keep those kids in sports like every day. And that's been my strategy for keeping them engaged, because I know that bored kids are not good kids. Okay? And so keeping them engaged in community. And what we know, and Dr. Gabor Mate speaks a lot about this, but what's missing from a lot of people's lives is connection. You can actually trace a lot of this back to the idea of the nuclear family, which is a new idea. It's an invention of Western ideology to have a 2-parent household with like 2.5 kids. That's a new thing. Historically, throughout our lives as like human species, we have lived in multi-generational households. And so there's a lot of anthropological and sociological data that suggests perhaps the nuclear family is lacking in some ways, because, to quote, it takes a village, right? And so in the absence of that, what we can do is we can make sure in our way that our village is very strong, right? Even if you're not a parent or even in kid, how are you contributing to the health of your community? Do you know your neighbors, right? Things like that really matter. And of course, empowering kids with evidence, just as my co-presenter spoke about. I have very candid conversations with my kids. They're tired of hearing me talk about Narcan, but I don't care. So we talk about that, and every time they go out, because I don't think I'd have to worry about you. Even if I did, that's fine, but you don't know who you're going to encounter. And so again, centering them with compassion for other human beings, I think is a good foundation for any person. And, times are tough out there. And so also, no shock here, but we're in a period of economic crisis. I'm not an economics professor by any means, but I'm sure everybody is probably feeling that pinch. And those types of social factors contribute to the incidence of issues within a society. So again, Lake County is a really special and unique place because we were galvanized, I feel like, in fire, and this community came together really strongly, and those partnerships, which are evident here on this stage, are a lot of the result of how we came together during those crises. So I think we're better equipped than a lot of other places to deal with this crisis head on, and I'm very encouraged with what the future might bring.
Thank you, Elise. That was a great question. There's been a lot of great questions. We really appreciate hearing those. Are there any more? Doesn't appear so. Again, I'd really like to thank everybody for coming, and those online. You can help us out. Help these agencies out by spreading the word, letting people know what's available. This has been recorded and live streamed. It's out there. Share it with a friend or a family member. Let them know it's available if they didn't have a chance to come watch it. I really encourage more people to, listen to this and understand what we're doing, because it's critical. Like I said at the beginning, we cannot do this without the community supporting us, backing us. We're going to work hard together, and this is just one piece. There's going to be much, much more to come in the future. We're not going to stop until we reach everybody we can, until we do everything we can to save lives in our community, educate our youth, educate the rest of our community. It's critical. So I really want to thank these folks again. Thank you, and that's it. Have a good night.